If someone came and evaluated my dog when in Arizona, they would say, he's depressed, he's amotivated, he doesn't want to play. What's wrong with your dog? Like he probably needs Zoloft.
Same dog, different environment. That's the conversation we're having today. Welcome to the One Thing podcast. I'm your host, Dr. Adam Rindy. Here's the one thing for today. Your brain probably isn't broken, even if you've collected a stack of diagnoses, even if you cycled through medication that didn't work, even if you've been told the next label will finally be the right one. There's a real possibility that the labels themselves were never the right starting question. I know that's a lot to claim, so I want to be careful with it. Today, I sat down with Dr. Stephen Rondeau, a naturopathic physician who spent the last 15 years reading QEEG brain scans, about 50,000 of them. His work isn't about replacing your doctor with a scanner. It's about what becomes possible when objective data and a person's lived experience finally start talking to each other. We get into the diagnosis chasing loop, why so many well-matched treatments still fail, and an analogy that's been rattling around in my head for weeks, what he calls the husky phenomenon. If you've ever felt like the system has tried hard but missed the actual you, this conversation will land. Many of these concepts can be read in his book called Think Like a Brain. Without further ado, here's Dr. Rondeau. Dr. Rondeau, welcome to the One Thing podcast. Thanks for being here today.
Hey, thanks for having me. I'm looking forward to talking about brain health and how we can take the guesswork out of it.
Quick note before we go deeper. When Dr. Rondeau says, take the guesswork out, I want to be careful, and I think he'd agree that the goal isn't to replace clinical judgment with a scan. It's to give clinicians and patients a piece of objective information they've never had before, so the conversation can start from somewhere other than a checklist. Same medicine, more data, less guessing isn't the same as zero ambiguity. Excellent. Same here. This is such a fascinating topic. It's great getting to know you a little bit offline, and we share the similar medical training, naturopathic medicine. I know you were in practice for a number of years, and now you're working on a different angle of your specialty. And can you share just a little bit about what intrigues you about the work you're doing today?
How long do we have? I mean, gosh, I could talk about that forever. I mean, I think the data side of things is what's fascinating. And we had talked before the show about some early work, particularly in autism, and all my work I had done in development of pediatrics was all around biomarkers. I mean, we didn't know what we were doing unless there was a biomarker. But then when we started this mental health clinic in 2009, and I sat down with one of the psychiatrists, I said, how do you know what to do? Like, how do you know how do you treat a patient? Because again, we're doing think tanks and, doing biomarker studies in autism at the time, which is how I met Dr. Fry, we were talking about earlier. And he, later became a good friend of mine. But we were doing all this biomarker study, and we come and sit down with the psychiatrist. I said, how do you know what to do? He says, well, we just listen to the patient, and then we hear their story, and then we match it with, the diagnosis and the DSM. And then that kind of helps us decide which treatment we're going to do. I said, well, hold on. You don't have any tests that you do? Like I had worked in developmental pediatrics, and I'd done neuropsychology, rotations, all of this stuff. So I was very familiar with how that world works. But when I got to psychiatry, I was like, what? You don't have any tests? Well, no, maybe a checklist, and then that'll kind of help us to narrow down the diagnosis. And I was just like, it really became a very interesting relationship of how do I talk to somebody like this, where we speak a totally different, language. And over the years, that relationship got nurtured gently. And I think the bridge of that was the brain scans. That was one of the transitional moments and pivotal moments of how do we bridge the world between, objective data and, subjective interpretations of people's lived experiences. It was fascinating, and it's really gone on to be something quite fascinating. And frankly, it's all I think about for like every waking moment of the day.
Yeah. It certainly is groundbreaking. And I'm sure for people who are accustomed to that 45-minute to 1 hour intake of questions, answers, looking for patterns,
Mhm.
and for them to meet modern science, it's sort of shakes the foundation. And, it likely requires an openness to say, that there is so much we don't know about the brain.
Right.
So what, besides financial, obstacles that people have with going further in testing, are there other incentives or limitations that keep the psychiatry field reliant on subjective diagnosis?
Yeah. I mean, it's such a big and good question to try to answer. I mean, I think, I don't know if I told you, but I have a book next month, Think Like a Brain. And a lot of the book talks about that in the nature of how psychiatry got to sort of where it's at, and it's a pretty long and I think interesting history of, well-intentioned people. But at the end of the day, if Abraham Lincoln were to time travel and come to 2026 and get an assessment, his assessment would largely look like it did back then. And so it would be questions and it would be interpretation. And then they would give treatments based on what was available, in 1835 when he was diagnosed with depression. And so yeah, there's a lot of limitations. And the path, is largely related to having a common language, which is the Diagnostic and Statistical Manual, which has evolved into its fifth version now. And it was largely made to help categorize how people's symptoms fit into a label. So you and I could have a conversation and understand, I have an anxious patient, I have a depressed patient. Well, then that evolved into ICD codes, which then translated to insurance reimbursement, which then became sort of a gatekeeper for treatments. Okay. And so, a lot of patients, I'm sure you've probably experienced this, like my insurance won't cover this treatment unless I do XYZ, or I have to do this and fail these treatments, then it'll cover this. And so it became basically this algorithm of, even if the diagnosis didn't really fit, we have to put something on the chart so that it satisfies the payers. And so it just became kind of a model like that. And what's eventually happened, and I hear this with patients on the message boards, suffering all day long, of it became this narrative of like, if I just got the diagnosis right, then I would know the treatment. Then my kid could get better. Then I wouldn't be so depressed. But what patients don't realize is, and this has been shown time and time again, is that there's little correlation between an accurate diagnosis, okay? Meaning that 10 people see a patient, they all have diagnose them with the same thing, okay? Experts. Little correlation between an accurate diagnosis and a favorable treatment outcome. So even if the diagnosis is right, it doesn't mean that you're going to get better. And yet what do? We go to one provider, we go to another provider, we're trying to get a diagnosis. And I'm speaking purely of psychiatric diagnosis. But then clinicians are guilty of this sort of narrative too, because, right, if a patient doesn't get better when they were diagnosed with depression, maybe the diagnosis was wrong, which means then a different treatment that goes with the new diagnosis. And then that cycle continues over and over. And so the well-meaning clinicians, they're just working off of an old framework that was really never designed to guide the treatment. But, that's such is life. And that's why, I'm here trying to take some of that ambiguousness out of this loop that we're stuck in with mental health.
So I think there's a good opportunity for us to unpack what you're actually revealing
Sure.
on your work. So you do QEEG scans. I'd love to hear a layman's explanation of what that device does and is. And what's it revealing that the traditional question and answer surveys cannot?
Oh, fascinating question. There's so much to unpack there. Well, first of all, EEG is measuring the electrical activity on the scalp of your, of your head. And we measure this very small microvolts and we send it to an amplifier and we can see the squiggly lines on the screen, much like a neurologist would do to see if you had, say, seizures or a mass, or if you had a head injury, someone might do an EEG. Okay. But what we do that's different in the QEEG field is that we quantify it, hence the Q. So we're quantifying the EEG and we're taking all the squiggly lines, removing all the noise, blinks, movement, all that sort of stuff. And we turn it into these enormous spreadsheets. Okay. And this is where things get really exciting, is because when you can quantify it, then you can start to make sense of the data that's there. So the EEG is valuable for what they use it for, and the QEEG is valuable for something different. Okay. So the QEEG then, we distill that down into established biomarkers that we know are either normal or abnormal, associated with different, pathology and different brain function and so forth. So we look at how much of the brainwaves are there and where are they located and what's their distribution, and all different types of mathematical equations of how we can compare the markers within a recording. Okay. So there's like an infinite amount of ways we can look at the data, but we look at the well-established ones that are associated with different treatment outcomes, treatment failures, diagnosis, and so forth, the ones that have been published on the most. We take that quantified data, which turns it into numbers, and we can then turn it into the pictures that people might be used to seeing, where you can see basically the maps of where the brainwaves are distributed. And so we've taken that now and applied it clinically in the real world to guiding providers to better understand what's going on with their patient, to understand, what's going on in that patient's head that they're trying to describe to us in words.
And when you take that information, is there an obvious detour in the treatment direction that you see when people are using your scans and subjectively a patient is DSM diagnosis of depression, or say single episode depression or something of that nature? What are you seeing deviate towards more when you get these scans? Is it more brain anatomy based diagnosis, brain function based diagnosis? How would that be different than this kind of name we've labeled depression?
Yeah, that's a fascinating question. Being stuck in this world looking at scans all day, some of that information gets left out when I'm talking, but yeah, exactly that is that we're looking for functional activity of how the brain is performing. The label tells us what the expression is of those patterns. Okay, the patterns tell us where dysfunction is, and I'm reluctant, and I pause there for a minute. I'm reluctant to use the word dysfunction because in the right environment, in the right ecosystem, aberrant brain patterns can be a wonderful thing. They can be a wonderful gift for us. They just need to be supported. And so the idea is, when you start to look at these conditions, okay, under the microscope of a QEEG, you start to realize that what we call depression is a very heterogeneous group of people. Okay. Same with ADHD. And I think people understand that largely with ADHD because we have things like stimulant medications and we have non-stimulant medications. And sometimes, if you're lucky, you're on both of those things. Okay. And that's when you can really tell as a provider, we don't understand what's going on with this person. Okay. If they're on an upper and a downer at the same time, we don't understand. Okay. And so, so we can look at those things. So how we sort of started to put these pieces together is 2015. Okay. I'm working in residential addiction center as a transition center for 17 to 25-year-olds getting out of wilderness, going into the real world after being sober for so long. We do brain scans on all of them, for various reasons, but everyone that comes through gets a scan. Well, this girl comes in and I look at her brain scan, had no information about her, which is not uncommon in those centers. They've been a bunch of places. We don't have much info. I look at her scan. I said, what in the world are you doing here? I've done 500 of these in this center. You don't look like anyone else that we've seen here. I said, you look like you have ADHD or like a learning issue. Like, what's going on? She says, well, I don't have ADHD. I have panic disorder. I've been in 3 residential centers. Okay, these are probably $15,000 a month. So she's not just like there for fun. Okay. I've been in 3 centers. Okay. And I've been on 40 different medications. And she was like 21, 22, something like that. So this looks like you have ADHD. Why don't we just treat you as if you have ADHD? I said, has anyone ever brought that up? No, no one's treated. No one's, said that. So go back to the prescriber, the team. I said, hey, this is what I'm seeing. They said, well, let's give it a try. I mean, the worst thing that could happen essentially was, she'd be up for a couple of days, agitated, irritable, so forth. We'd just try a short acting stimulant. Okay. So we did. And that was the end of her panic attacks. This is a woman who had been through so much, and she was in this center. They didn't know what else to do with her. She's in an addiction center, but she's there for panic disorder. Okay. Because no one else knew what to do with her. We treated her with probably $1 a day medication, and that was it. And that's when we're like, oh my goodness, we need to look at the scans and see what the scans say. And then we can translate that to what the people are saying. Okay. Cause she was saying, I'm anxious and I'm panicking. But what we were seeing in her brain was disorganization and overwhelm. Okay. And so in some ways it's a semantics issue. It's a linguistic problem that we just don't have language for. We don't differentiate overwhelmedness from anxiety, but on a brain scan, they look drastically different. And hence they respond drastically different to treatment. So that's kind of how most of it got started, was around 2015. We had been doing it already for whenever, like 5-10 years or something. But that's when we really hit the ground running to say, oh goodness, like there's a lot of data here. Like we can tell that this person wasn't going to respond to any anxiolytics. She needed to speed her brain up, not slow it down. And, the rest is history, some 50,000 scans later, So
That's a great example and really hits home with, the puzzling complication of making a diagnosis and, the common experience with people who, they're called non-responders. And, that was really helpful.
Well, think of it from a provider standpoint too. So imagine, I know this was the case in our training, was mental health training was pretty limited unless you were focused on just doing mental health. And as a result, I think mental health was kind of scary. Like, what do I do? At least it was for me, because I'm used to numbers, data, algorithms. Like if I can't measure it, I don't know what to do with it, And so think about that going into the field, and you're like, hold on, you just listen to them and then kind of guess what to do, how does it go forward, As a provider, you're getting out of school and you're like, this is intimidating. I'm a PCP. I have to be able to treat all this stuff. And here's this kid who's biting his teacher and kicking the dog. I don't know what to do. What should I do?
If you're listening to this as a parent or someone who's been on the patient side of this, not the clinician side, I want to make sure this lands for you too. What Dr. Rondeau described, that pressure clinicians feel when they're guessing, is the same pressure you feel sitting in the chair across from them. The fix isn't that you need a brain scan. The fix is that the model itself was never built to handle the variety of what shows up in real human beings. Hold on to that as we keep going.
But if you have some data to support your thinking, your processing, and say, oh, this is a regulation issue. This is an under arousal issue. This is an environmental issue, and the brain scan looks totally fine, then you have data to then make some assumptions on, so that it can give you more confidence about moving forward. And so, same with patients, it's not just providers, it's the patients understanding their brain and their kid's brain too,
As you were talking, I was thinking about other labs that we've used for mental health evaluation, in the field of naturopathic medicine, specifically, we're doing some nutrigenomics, we're doing organic acid testing, we're doing neurotransmitter testing, but, nothing compares to what you're doing. And even with those tests, the establishment of norms versus abnormals is really difficult.
Yeah.
I'm just curious how you're going about that and establishing what the brain in a not, say, for example, in a non-ADHD brain versus how you flag this particular patient? How are you finding that data?
Man, that is a amazing question. And I think that the easiest way to answer that would be to go back even a couple questions ago, which is, you know, part of the reason why I think mental health providers, largely psychiatrists, um, are gun shy to use testing in their practice because of the experience they may have had that was less than favorable when it comes to some of the objective testing. I mean, recently, sort of one of the big topics in mental health was this sort of debunking of this brain chemistry theory, around depression and that it's serotonin deficiency and so forth. And so it's made mental health providers skeptical to begin with. I think the genetic testing has done that in some ways too. We were some of the earliest adopters of that, using these genetic testing in sort of the beta phases and using the EEG on parallel. And so I think I would love to talk to some of those other tests, but I know way less about them than I do with what I do. And what I can say to the EEG data is when it comes to normative ranges and normative values, there has been a long history of normative databases, which has plagued the field in some ways, or was controversy around how do we define what is normal, okay? What is normal now? What is normal 10 years ago when it comes to attention spans? We know that's changing, okay? That's like been done, These things are changing, okay? And so what myself, our group, and several other people in this space have started to do is to look at the data in the absence of like what we call normative databases or normative ranges. And so what we tend to think about is, and this is a little high level, but bear with me for a second, that none of the patterns in themselves are abnormal. Okay. So having a certain brain pattern, we measure about 12 different patterns in our reports, but none of them by themselves are bad. It's bad in the context of an unsupported environment. And that's when you see symptoms. Okay. So let's just talk about our friend in the addiction center for a second. She had what I called an ADHD brain. I was using that term so we could talk about her brain patterns. Okay. So she has an ADHD looking brain. In a supportive environment, an ADHD brain could look like an artist, a musician, a kid in a Waldorf school, a marketer, a graphic designer. Those are spaces that support those brain patterns, okay? If we support those patterns, and I'm grossly oversimplifying, but if we support those patterns, largely those people don't have symptoms, or at least not enough to bring them into a clinic for treatment, okay? When those patterns aren't supported, the check engine light comes on, the teachers call, they get kicked out of the school or the marriage fails, like whatever happens, and we come in for symptoms because our kid is acting out or we're depressed or whatever. And that is a sign to us that there's a mismatch between our brain patterns and our ecosystem. Okay. And what we want to try to do is to work on the external environment to support that, and perhaps the internal environment with whatever tools you use. So do you want to use meds, herbs, supplements, or neurotherapies? Like, it doesn't matter. But what we want to try to do is show people that their brains aren't broken. Okay. They're mismatched for their environment. And that's the part where we have to sort of get out of this DSM model, because as long as we try to do that, it makes it very hard to have a study that says, here's 10 people with depression, but you have 10 different brain scans. This test is bogus. No, it's not. It tells us that the way we label the conditions is grossly undersimplifying the complexity of the human, experiences. And so if we can take those patterns and support them, again, with treatments or with environment, that's when we see people flourish, and that's when we see people thrive. And so, yeah, I think it's a fascinating world. And frankly, when you look at 50,000 scans or more, you start to wonder, like me, how any of us get along at all, because my lived experience and your lived experience is drastically different in terms of how we process what's happening in the world right now. It's totally different. And it's just fascinating that we any of us get along. It's fascinating.
Yeah. that really lands well with me, and thinking about the aspect of how empowering it must be for people to get this message versus getting a diagnosis and a medication that everybody else is getting, a similar kind of standard medication.
Yeah.
This is much more individualized. It's taking the unique aspect of each of our brains and how we function best, and taking that all to account.
Right.
So very empowering. So that links well with something that you talk about called the husky phenomenon. And I really like that analogy when I was reading up on that. It'd be great to hear it from you specifically about what that is. You alluded to it earlier, but I'd love to come back to that and talk about, furthering that. So
Yeah.
talking about the husky's natural environment, and then what happens when the husky is out of its environment.
Yeah, that's fascinating. I remember I was sitting in this spot right here, probably a year ago when we were writing the book, and we had just gotten a husky. Okay, he's sleeping or eating something out here. I don't know. We just gotten our first one, and we were talking about how when we take him to Arizona, he's miserable. He's got 2 coats, and he's bred for the snow, and he likes to run around. And when we take him, we drive in the RV down to Arizona, and we get there, it's 100 degrees. And he's like, this is terrible. If someone came and evaluated my dog when in Arizona, they would say, he's depressed, he's amotivated, he doesn't want to play. What's wrong with your dog? Like he probably needs Zoloft, like what's going on? I said, well, no, when we were at Winter Park here in Colorado last week and there was, 2 feet of snow, he was like loving the world. Arguably he was manic. He was so happy. And I couldn't get him to come in the house. And he was totally fine. So you evaluate him there in his environment. He's happy as can be. He's doing great. You evaluate him in Arizona. He's suffering. He's struggling. And there's something wrong with him. And so that's how we came up with this husky phenomenon where, a dog in their environment and, what they're bred for thrives. And when they don't, that's when you see friction. And that's how it is with these patterns that we see in people's brains, is that depression patterns thrive in caregiver roles. When we did our study on first responders, almost all of them had similar, what I call sort of compassionate brain patterns. They had patterns that look like depression, but when you're giving to other people, when you're caring, when you're volunteering, you're teaching, nursing, that itch gets scratched for you. Okay. You take that person out of that role, have them watch the news, do some other things, like it's going to lead to more depressive like symptoms. Okay. It's the same with the artistic patterns. It's the same with the anxious patterns, the overwhelmed patterns, all these antisocial patterns. They have very distinct environments that support them. And when they're not supported, it doesn't feel good and it looks like symptoms. And what's really fascinating, we have this unique experience here studying niche groups, from police to first responders to now military folks. And we've studied a lot of veterinarians. And there is 2 common patterns across almost every veterinarian we've ever scanned. And it's really interesting because in the world where you're giving back to animals and supporting animals, and frankly, interacting with animals more than you are with people, those patterns thrive. But you take that away, you take the animals away, the caregiving away, you have a person who doesn't feel good socially, a person who rather play video games than, interact with people in real life, people who, do engineer desk jobs and they don't, go door to door selling vacuums or whatever. And it's like, if you tried to get those 2 people to be in the different environment, it might look like they have symptoms, but it really is this mismatch between their hardwired gifts and the environment. And I don't want to oversimplify because it isn't as easy as just, changing your job or getting a puppy, but little things change in that ecosystem, just like the dog. We need the yard. We need, no neighbors. We need 4 walks a day. We need exercise. We need to groom them. And you do all of those, it's a great dog. You don't do those things, it's going to hand out,
And you alluded to that, there is a little bit of simplification in this conversation, just because we're learning a topic and we're trying to wrap our head around it, and simplification always helps with that. I'm going to detour just a bit because there are conditions that keep popping up, and what I'm thinking about in our conversation that may have maybe a different spin on things. So, for example, brain trauma or post-traumatic stress disorder. Do we derive with your data the same kind of conclusion that they just need to change their environment and their patterns improve, or are these unique scenarios that deserve a separate type of interpretation?
Yeah, it was a good question. I do want to clarify though, one thing about the environment. When we talk about the husky, we're largely talking about the external environment, but internal environments play just as big of a role, right? So like I think of internal environment as, neck down stuff, but also, the right medication is part of that too, and so if we're giving, you know, the wrong medication to the wrong brain pattern, that's an environmental mismatch, as well. So yes, head injuries is an interesting one. And I imagine you bring that up because those tend to be some of the hardest folks in practice. PTSD and TBIs, especially if you don't even know if that's part of the equation. Like, maybe this is it. I don't know. Let's try some of these things. So I'm guessing for you, that's been some challenging cases.
For sure.
Yeah. So there's a lot of different angles with this because we've worked with so many different populations, from the police to, football players to, all kinds of stuff. But I think what the data does is it opens up a conversation. Okay. It's not like a fortune telling or a magic 8 ball where you look at it and you say, oh, you had a TBI. That's right here. I see it. No, it's a conversation that says, hey, these patterns you have. So I have a patient right now like this. Okay. Who is high level, highly educated, went to school until they were 30, professional, all the good stuff when it comes to school and education, completely treatment resistant for like the last 20 years or something, as far as depression goes, suicidal, not in a good place. Okay. We looked at their brain scan. I said, there is no way you went to school until you were 30 with a brain scan like this. There's no way. Nobody goes to school that long because school is challenging with brain scans like this. Tell me about it. She goes, well, I said, tell me about the injury you had. Is that what happened? She goes, well, I had this sports accident. I ended up on the ground, bloody, blah, blah, blah. I said, okay, I think that's when this started to happen. If we keep treating you as if you're depressed, we're probably going to have limited return. We have to treat this as if it's more of a head injury type of an approach. And so the treatments that ensue that have to do with, recovering from TBIs. And so we feed that back to our providers and we tell them, this is what we see, and, go about doing your, TBI, sort of protocols and so forth. So yeah, I think it opens up the discussion around, tell me about this thing. Tell me about it paints a picture around a story of a mismatch. And there's, like I said, there was no way that person would have gone to school that long with patterns like that. So it opens up that conversation, just like some of the patterns we see around, different types of addictive tendencies. Tell me, what do you do for fun? What hobbies do you have? What sports do you like to play? And then we start to think about, okay, what type of environment would that look like, where someone would do those activities? Because if they're not, they're getting their needs met some way. Tell us, what is that? What is that? And so, yeah, that's actually opened up a lot of conversations over the years around people who have been, kind of treatment resistant. We say, I don't see this in your scan. Tell me more. And they say, well, I was abused when I was little. I didn't tell anybody. And now it's coming out. Or I was in a marriage that my husband abuses me, but I'm afraid to leave. And it becomes a conversation with or without the presence of, supportive findings. Both ways is good. Just like the findings, they're neutral. It just starts a conversation. So yeah, interesting question around that. Head injuries is a tricky one. And I imagine most of your patients who are labeled with, treatment resistance, there's probably signs of that. Not that it matters so much, but once you have the data, then you can guide the treatment the right way then,
Yeah. So I think that both from the patient's perspective and the practitioner's perspective is that, when you're making a an ambiguous diagnosis and what's being offered as treatment is necessarily a big leap or a big investment or with no promise of return on your investment. I think where a lot of these conversations drop off, meaning, well, it may be a TBI, or this may have started with a brain trauma. And if it is, then this is what takes place. So when people are working with your system, do you find that you're coming back to the clinicians with a report that, strengthens their confidence in making that call? I mean, I imagine that's the whole idea, but I'd love to just kind of hear it from you.
Yeah, I mean, it's one of those things that, like, when you see the world through that lens, it's very hard to unsee it, right?
That phrase, you can't unsee it, is one I want to translate. What I hear Dr. Rondeau saying is that there isn't one true lens. It's that once you've seen depression present 10 different ways on a brain scan, you stop being comfortable with a single label doing all the work. That's his own clinical maturity catching up with the diversity in a mental health diagnosis that's always been there.
So when you start to see that depression could show up 10 different ways, ADHD 10 different ways, anxiety a dozen different ways, like it becomes, almost, it just seems sort of wild to think of it any other way at that point, and it's more about, validating the lived experience, showing them that they're not broken, validating why 20 treatments haven't worked. And, it's just as much of a tool for the providers as well, because then the providers are like, and if you could imagine having especially in a practice like yours, for instance, I imagine your practice isn't like the first stop for most people. It's like, I've tried a lot of stuff. I'm going to see this person, and this is my last, $100 I got to do this. Okay. And I've been in that position. It's a lot of pressure. And so imagine if you're going into that and you're like, man, I got to help this guy, or he's going to, I don't know what's going to happen. I'm worried about him. Without data, that's a lot of pressure, man. That is a lot. And so if you have the data and you say, okay, hey, here's what we see in the brain scan. This is why those 10 treatments didn't work. We're going to try something different this time. And now you can go in with more confidence that your interventions are going to be, helpful. And it's not just, this isn't like my word or my, empirical evidence. This is like biomarkers based on all the published data that we have. When we first started in 2017, it was just a repository for data. Like, that's all it was. It was just a place to dump all the brain scans and kind of do cool stuff with it, do presentations, make connections, do cool stuff. But then something magical happened in 2017 is this AI thing came out, and it was like, what's this all about, And then we could start to apply AI tools to the data and see all kinds of things we couldn't see. And that's when the dots started to get connected with suicidality, which is when we then published our first paper on predicting suicide with EEG biomarkers. And so, I think it adds a layer of confidence to a lot of different scenarios. At the front end, which is where I would love it, is you're getting to know your kid, you're getting to know your spouse, you're coming in, learning their strengths from the get-go. Are they in the right school? Should they play baseball or soccer? Like, these sorts of things, because you understand their brain, right? But unfortunately, most of the time we catch like a friend I'm talking about who's last $100. This is the last thing I'm going to do, and I'm burned out. And so that trickles into the, provider burnout, as well. And so if we didn't have to guess all the time and deal with that stuff, like, it would be, I think there's a lot more satisfaction that goes on both ends, And so it's not perfect by any means, but it's a way to get past the guesswork,
So I want to, perhaps if we have time, come back to talk about the paper you published. However, I want to check in with other conditions that may overlap. As you've been talking, I've been thinking about patients with, say, chronic fatigue syndrome or long COVID or Lyme, in other conditions such as cognitive decline or early dementia. And are you serving these populations as well in from a brain health perspective?
Yeah, good question. We do have a couple of clinics that are specific to cognitive, mild cognitive impairment, dementia, memory centers, those sorts of things. So we've worked with a number of those. But, again, those conditions are heterogeneous too, right? So we have people come in with memory issues who, a one size fits all approach clearly doesn't work. That's why I can see one out my window right now. There's a memory center right there, and then there's another one over there, and it's like if everything worked, then we wouldn't have these places filled up. So they're not homogeneous groups. They're very dynamic and very different. And so we need to look and then approach our treatments the same way. And that could be behavioral treatments because the memory issues are due to temporal slowing, and we need to coordinate our care around auditory processing and, memory, or is it around a processing issue where we have slowing in the back part of the brain and we just can't process that information, almost like our iPhone's outdated and we need to like update, or do like a new phone. So there's different ways these things all show up. And without understanding that, it just becomes guessing and everyone gets frustrated because you're like, hey, it worked for that patient. Why the heck isn't it working for this one? I don't get it, And so that's what we're trying to do is to not necessarily pick on any one, population or any one like profession, but it's to say, hey, if you're doing stuff in the brain space, we need to stop guessing. We need to look at, what's going on under the hood, who actually needs that formula that's, when you walk down the aisle at the vitamin store and it says anxiety and there's like 170 different formulas there. How do you know which one's going to work for your kid or for you? And if, like I said, there's 12 different patterns that could look like anxiety. How do you know which one it is for your kid? So, how many of those trials do you do before you bought a brain scan? You know what I mean?
Yeah.
Yeah, it's tricky. And again, as a provider, man, it is exhausting when you're like, this should work. I know it'll work because you're depressed and this is the depression treatment and this is going to work. And I come back in 2 weeks and they're not any better. You're like, oh, this is so frustrating, So yeah, the memory stuff is a big one. You said cognitive. Yeah, I mean, I think there's a number of different groups, but it starts to give you a conversation around what's there and what's not there. So for instance, I remember a case where we had a lady who was quite young for memory issues, 40, 50 or something like that. Looked at a brain scan, looked relatively normal. I went back to the provider. I said, hey, what's going on? I think I was doing clinical work then. They said, yeah, she's got all these memory issues. She's going into a center. The family's putting her up, and no one can like figure out what's going on. I said, I think I would look somewhere else. I don't think it's a brain issue. And they went and looked. The lady had like, I have the chills right now because I can remember this. She had like copious amounts of lead. I treated the lead toxicity. The lady was totally fine. Totally fine. Yeah. We had another one too. We had a lady who was schizophrenic. Okay. She would come in from out of state. This is like hospitalized, like looked bad. She was rough place. Okay. She comes in, we do a brain scan. I look at the brain scan, go back to the group. I said, hey, what's going on with this lady? She just came from like 5 states away. What's she doing here? She says, oh, wow. Yeah. She's got this and this hallucinations and this. I said, yeah, I don't see that there. I don't see it. And I said, you guys got to look somewhere else. And at that time, this is what we were talking about before. We had just started using the folate receptor antibody test. This was when it was done at another lab prior to how it's done now. And I said, let's look at some brain antibodies. Let's look at some other stuff. And we found that she had folate receptor antibodies, treated the folate receptor antibodies, totally normalized her psychiatric symptoms, and then went on, this is wild, to have a child. She thought she was infertile. Well, again, it was a folate receptor problem. She went on to have a child, which she never even thought she could have. So you have now, 2 people's lives drastically changed by the absence of data in a test. How amazing is that? It's so cool. But if people would go on, and I have a friend, this was the case too. I won't tell you the story. It's too long, but 3 people I can think of just off the top of my head whose lives would have totally been debilitated, needing care, affecting the whole family because they were treating the wrong thing. It's crazy. I'm sure you've got a bunch of those too. I just have them through the context of the brain stories, but I'm sure you have a bunch,
I want to pause here because stories like this can sound almost too good. And I know my audience tends to be appropriate skeptical of anything that sounds like a miracle cure. So let me name what actually happened here in those cases. Nobody cured anyone. What's happened is that someone looked at data instead of staying inside the existing label. The lead toxicity, the folate receptor antibodies, those are medical findings treated with conventional approaches. What changed wasn't the medicine. What changed was that someone asked a different question. And that's the through line of this conversation. Not that one tool fixes everything, but that the wrong starting question sometimes keeps people stuck.
Yeah, I mean, I like how you said that once you see this, you can't unlearn it, because I think that really describes these situations. The first time I was introduced to psychiatry through this lens, I'd heard about one or two cases like this, and then you start seeing more and more and more and more when people have been cared for in a more comprehensive way, and you realize how many people have been given these lifetime diagnoses, and some people even institutionalized,
Right.
and nobody took nobody knew or was aware that there were other levels to explore. So
Yeah, especially in the suicidal population, I think that's a big one where, looking at the information and getting an idea of really how much that person is struggling, which is kind of my baby is the suicide stuff. And kind of unpacking that, because frankly, a lot of people who are struggling with suicidal ideation don't tell anybody. And a lot of first attempters never told anybody. And so if you can see that information in the reports, you can start to have that conversation. Obviously, it's a very delicate conversation, but it's a conversation nonetheless. Tell me about your negative self-talk. Tell me what you do when you get overwhelmed and you feel despair. Tell me these things that we can start to have the conversations about self-care and, how do we support those people who might be at higher risk. So it's really an interesting area. And I think one of the things I definitely want to clarify, at least for the providers who are listening, is that it's not something to kind of pick up on the weekend, right? This isn't like, I see patients during the week and then I moonlight, to kind of wrench on hot rods. Like, you really want to hand it off to someone who, like, that's all they do. Like you don't know how to do an ELISA test in your lab, I assume, but you do know how to draw the tube and send it to LabCorp or whoever and have them spin it. And they send you a piece of paper back that says, hey, here's the value. That's what needs to happen in this field. And if you try to do it yourself, I mean, it's a lot to take in. And frankly, if I knew that's what I was going to get into when I got into it, I highly doubt I would have gotten into it. It was so much to like unpack and learn, but it's been so rewarding. But it's a lot. So I would just say that you want to work with providers who do this and can get you the information, and then then the providers themselves offer it as a service to help their patients.
yeah. So since suicidal cases or populations or people who are dealing with suicidal ideation is part of your personal core interest, have you seen personally situations where you've been able to extract those conversations that weren't going to be had?
Yeah, I've had a couple of really, really, some of them are hard to talk about, but I've had some that were really pivotal in making us push forward on that. And I think some of it comes down to talking to men about their struggles, you know, like this pattern looks like someone who, might struggle in this area. What does that mean to you? Does that resonate with you? Yes, no? Okay. Or having that conversation with a therapist who, has that conversation with them. But that, I think it opens up, the dialogue. And I'll never forget the one time that really stood out. We were only about 7 or 8 patients in. We had basically this amalgam of patterns. It's the most complicated group of patterns that we look at right now currently. Okay. Most markers, 1 or 2 markers, that's kind of how we do it. But this is about 5 different markers we look at together. And when those 5 are present, they match to a patient who completed suicide. And they also match to now several hundred people who have all had attempts. Okay. And so this work we're trying to publish. Our initial work was a review paper of the literature. This is the original research that we're working on publishing now. Okay. And so we have these biomarkers we think can do this. And so when we had started, we had 7, 8 patients matched this profile, and we were working with a group. Without getting into the names, they were a group of professionals sort of prone to suicidality. At that time, we were looking at stress markers, and we wanted to help them with stress so that we could identify this person handles stress this way, this one handles it that way. And so we would go back to the group and say, okay, this is how we can help you. I said, we're doing this tangential project. We could probably identify the higher risk suicide folks in your group. And so the person who was doing this sort of interview was kind of the entry point to this group. And we had done a scan on them, of course, because it was like, hey, you got to test drive the car first, So just, and they said, well, what do you see in my scan? And so I'm looking, and I was kind of slow at the time. We didn't have all these fancy tools we had now. And I said, oh my gosh, this guy's got all these markers. How am I going to tell him? It was during COVID. We were on Zoom, the whole room full of people. And I was like, well, you got the markers, man. I was like, I don't know. Maybe it's, buggy. We got to work it out. Like, we got to figure this, this thing out. Like, we got to work out the kinks. But you look like about 10 other people have had attempts. And this is very new information. We got to prove it. He goes, well, I never told anybody, but I had an attempt 10 years ago. And this is the first time I'm talking about it, And so I was like I was just like blown away. Like, this is crazy. Like, I know nothing about you. And I could tell that you look like other suicide attempters. And so what do we do with that information? How do you translate that to a parent? I don't know. I'm a data person, how do you translate that to? And so that's what we want to work on and validate and really get this information out there to help, to help people. Obviously the suicide stuff is, sort of happening in the background, but in the forefront is where, the day-to-day like application we can do right now,
Well, this has been fabulous talking with you. I know you've got to run here in a minute, so I'd love to just kind of wrap up and hear anything you'd like to share with us or providers, and how people can follow your work or get in touch with your work.
Yeah, I mean, the biggest thing is just understanding that when you have symptoms, it isn't that your brain is broken. There's so much hope if you can look at the data and support those patterns, even if the data says your brain looks like it doesn't have anything going on. It's still data to tell us we need to look somewhere else, which is, of course, more of an obscure, rare kind of situation. But the point is, not broken. Once we have the data, we can work around, supporting it. And so, yeah, all of that has been distilled down into, a couple hundred pages in our book. Depending on when this is released, it's the end of March. That'll be out, and it's called Think Like a Brain, and it's for anyone struggling in that space, providers, patients, people tired of the system and want to change. It's there. So thinklikeabrain.com and then Axon EEG Solutions.com, and then we can help you get connected to providers who are using this as a tool in their practice.
One last thing before we close. If you're listening and you've been in the cycle Dr. Rondeau describes, the diagnosis chasing loop, the trying one more thing, here's what I'd offer that doesn't require a scan, a book, or a new provider. The next time a treatment hasn't worked, instead of asking, was the diagnosis wrong? Reflect on this episode and try asking, is the environment matched to how this brain actually functions? That's the husky question that Dr. Rondeau mentions. You can ask it about your kid, your partner, yourself. It won't answer everything, but it changes which questions you ask next. And in this work, the question you start with is most of the battle.
Well, I'm not someone who exaggerates very often, but I will say that you're doing groundbreaking work, and, I hope people appreciate this as much as I do, because it's opening a whole area, a pathway where people can get help sooner and not struggle for lifetimes trying to get answers.
Yeah, absolutely. So maybe we can pick this up again. It was definitely a good conversation for sure. And
Sounds good. Much more to talk about. So yeah, I'd appreciate, circling back another time and get into some more discussion. So thanks for being here.
yeah, my pleasure. Thanks for having me.
Thank you so much for tuning in to this week's episode of the One Thing Podcast. Please share these episodes with your friends, loved ones, colleagues, patients, healthcare providers, anyone who you feel might benefit from hearing these informative interviews. We tend to learn best from people sharing things with us. That's often the first time it's introduced. So don't hesitate if the content of these episodes reminded you of someone that might benefit from that. Forward the episode to them, and I'm sure they'll either appreciate it or be appreciative that you've thought of them. So once again, we'll look forward to seeing you next episode on the One Thing Podcast. And again, much appreciation for you being here with me.